Hey guys, and welcome to the BackTable videos. My name is Chris Beck, and I'll be your host today. Our topic today is lumbar punctures. I thought we would tackle this one in video format. There are lots of different ways to do this very straightforward procedure. I will show you my technique, but there are plenty of ways to get this procedure done. If you, our audience, have suggestions or comments, please put them in the comments section below and we can all benefit. Now let's get into it. The patient I'm presenting here is actually a myelogram. I'm using this case to demonstrate the technique for a lumbar puncture. The post-injection images that we'll get at the end will help you understand the thecal sac in relation to the bony landmarks. This is a PA shot of the lumbar spine with the patient prone. You'll notice the patient has 5 non-rib-bearing lumbar vertebral bodies with hardware at L4, L5. If possible, I avoid sticking at the surgerized levels. The next shot we'll go into is with the patient obliqued. For a fixed II, positioning the patient is key. I oblique the patient into the LAO position, so with the patient prone, I'll either place a wedge under the right hip or just have them bend their right knee to prop up the right side of the body. Here is a cartoon showing you a patient in the LAO position. For these procedures, I typically work on the left side of the table. Our rooms are already built out with easiest access from this side of the table. So with me on the patient's left and the patient in the LAO position, the back is oblique slightly towards me, which gives me a better visual of the back and easier access to the skin entry site. Back to the oblique shot. This is the actual image I start with. With the patient obliqued, I count the vertebral bodies. The conus should end above L2. I will typically access at L2, L3, followed by L3, L4. Every case can be different, but for many patients, L2, L3 will be the shortest path from skin to target. Next, I identify the interlaminar spaces, which I will outline for you. L1, L2 is outlined in gray, L2, L3 is outlined in yellow, and L3, L4 in black. As you can see, the L2, L3 interlaminar space projects on top of or over the L3 vertebral body. Let's segue and talk about lumbar puncture needles. This can be a topic in and of itself. I've used beveled needles for a long time for lumbar punctures and only recently started using pencil tip needles. Examples of these include the Sprott, Gertie Marks, or Whitaker needle. Sometimes they are referred to as, quote, atraumatic needles. The tip is designed to displace the dural fibers and decrease the risk of post-dural puncture headache or spinal headaches. Here's a great review paper on this topic. You can access this paper for free, and the article goes into great depth, fleshing out this concept of atraumatic needles and post-dural puncture headaches. After a few spinal headaches, I recently changed my practice to include the pencil tip needles like the one you see here. There are pros and cons. Of course, a pro is decreased chance of spinal headaches. As IR docs, we are really familiar with beveled needles and use them all the time, so there can be a bit of a learning curve with the pencil tip needles. I will say that I asked my partner to use one. He basically couldn't get it through the skin and immediately proclaimed it a piece of junk. So just a warning, they can take some time getting used to. After I pick my level, I mag up and column it in. With hemostats, I'll locate the skin entry site and mark it off with a Sharpie. In patients who have trouble complying with positioning, which is common with lumbar punctures, you will probably want to widen the field of view to accommodate more patient motion. Keeping the image tightly collimated helps me reduce parallax and keep my hands out of the picture. Again, I'll draw out the contours of the interlaminar space to help you see it. Next, I'll place my needle on the patient's back and line it up for access. Even though the interlaminar space is large here, I suggest accessing closer towards the patient's right. With this obliquity, patient's midline is usually further to the right than you would think. I will show you a picture later on that exemplifies this. Now I'm advancing the needle and I'm starting to feel heavier resistance. What I'm feeling is the interspinous ligament, which is denser than subQ fat. One of the advantages to this oblique positioning as opposed to a midline approach is decreasing the amount of ligament you'll encounter. The ligament has a way of pushing your needle off target. Many operators report feeling a loss of resistance when they pop through the dura into the thecal sac. For the most part, I don't feel this. Once I hit ligament, which is easy to identify, I advance a few more centimeters, remove the stylet, and check for CSF. If I don't see CSF, I replace the stylet, advance a bit, and then recheck. Here's a shot of the needle once I'm in. For lumbar punctures, all that matters is getting CSF back. You can use biplane or cross-table laterals to check your position, but if you're getting back cerebrospinal fluid, that's all that matters. Another good reason to access at L2, L3, which you can see here, is typically you have the L3 vertebral body as a backstop. Hitting the vertebral body can be painful and can also result in a bloody tap, but it also lets you know when you've gone too far anterior. If you hit bone, pull the needle back a few millimeters and check for CSF. As I mentioned, this patient was a myelogram and not an actual lumbar puncture. I used this patient and the contrast injection to demonstrate the position of the thecal sac while the patient is obliqued. Take notice of the relationship of the needle to the thecal sac. There's actually more thecal sac to the patient's right. On the next frame, I'll show you a picture of my needle position with the patient flattened out and in the AP plane. Because I take a paramidline approach with lumbar punctures, the needle has a tendency to cross midline. That's fine, it's not a big deal. I point this out because I suggest hugging the right side of the interlaminar space. You'll have a shorter distance to travel from skin to target and more chance of ending up closer to midline, presumably a better spot to tap CSF. We used to keep patients anywhere between 1 and 4 hours depending on the interventionalist, and we still have some variability within our practice. For me, because of this review article primarily, I've moved to 0 bed rest with immediate discharge. This paper also covers hydration, and although fluid supplementation in prevention of spinal headaches is unclear, I still recommend to my patients they stay well hydrated the day of the procedure, but we don't give IV fluids. Ladies and gentlemen, that will wrap it up for this video on lumbar punctures. I hope you enjoyed it and found it helpful. There were a few more topics I wanted to get to with lumbar punctures, like whether or not aspirating CSF is safe, when to get a head CT pre-procedure, and large volume lumbar punctures. Unfortunately, I just ran out of time. Maybe another video is going to be in order if you guys are interested. If you have any questions or comments, hit us up on the website. That is BackTable.com, or leave them in the comments section below. Thanks again for watching.